Professor Ashish, you can start now.
Yes. Now I should start.
Yes.
Okay. Hello, everyone. Good evening. With you, Professor Dr. Ibrahim Hashish. Uh, I'm talking to you from Jeddah, Saudi, from Saudi German Hospital in Jeddah. Um, I'm the maxillofacial consultant and the head of department in the Saudi German Hospital group inside and outside the kingdom. It's my pleasure and it's our honor today. Our speaker today, Professor Dr. Martello Hoshman. He is the chief surgeon at the Facial Surgery Center in South Carolina, USA, and he is the medical director and the founder of the Hemangioma Treatment Foundation in USA. The title of the lecture today is Vascular Anomalies. It's about hemangiomas, malformations, venous, lymphatic, and arteriovenous. It is a great pleasure and a great honor for all of us that they come that we with Professor Martello Hauschman. And we are thankful for him to accept this invitation. My colleague, the panelist, Dr. Muhammad Abu Saud, oral and maxillofacial surgeon. He is running a part of the maxillofacial surgery in Saudi German Hospital in Riyadh, in Saudi. And our dear colleague also, Dr. Muhammad Ali Abdel Munem. He is a vascular surgery consultant in Saudi German Hospital, Asir, in Saudi. So please, Prof, we are listening to you, and again, we are very glad and honored to listen to you. Please, Prof.
Thank you. Thank you, Professor Hashish, and thank you to Saudi General for the opportunity and the invitation to be able to be here with you. And as the professor said, hopefully someday we'll be able to do this in person and be able to establish perhaps a center with multidisciplinary participation that will benefit these children. I would like to share my screen and the topic, as was alluded to, is vascular anomalies, and what I think in general you ought to know in 2021. The topic is very broad, so I'm going to give a very broad overview, but then try to focus a little bit more on some of the most common things that you might see in a vascular anomaly center. As with everything else in medicine, we have to be first involved in what is the diagnosis. And even though these two lesions look very, very similar, they're totally different. This is a child whose tumor was not present at birth and rapidly appeared. And this is a tumor or an entity that was present since birth and has slowly gotten bigger. This is a hemangioma. This is a venous malformation, and they have totally different prognoses and treatment options. Same as this, we have two very similar lesions in a very, very young child where the lesion is just appearing, and then in a young adult where the lesion is progressing. And it turns out, it has been documented in the literature, that almost 30% of vascular anomalies that present to a tertiary care center are misdiagnosed. And that leads to, 60%. That leads to improper treatment. And we'll discuss these children a little further on. So the next question is once you know what it is, then what do you do about it? How do you intervene? Do you How do you treat this child who's very, very young and has potentially visual problems, developing vision? Here you have another young child with a lesion that is just appearing. Again, we know what these are, and we'll talk about how to tell what they are, but then what do you do? A little bit older child where this tumor has already declared itself, and what is the prognosis long-term for this? And then how would you intervene at that time? Or do we wait until something gets to this size and then wait and see what happens? Or do we intervene then? And clearly the same thing as you get more and more extreme. So not only do we have to be very precise about the diagnosis, but then we need to talk about how do we intervene, what the timing of that intervention is, not just what the intervention is. So if you think about this slide, which is probably the most important slide in the whole talk, so we could stop now and just talk, but vascular anomalies is the big family. And on one side are the tumors, and on the other side are malformations. And this is the key. The tumors are true neoplasms. They have endothelial cell hyperplasia. They're derived from endothelial cells. They behave like tumors, like everything that we know about tumors. There's increased mitosis. There is a growth, and most of these are sporadic. There's really no genetic component to these. On the other hand, malformations, it is an inborn error or vasculogenesis. So there is during embryonal development, there is an anomaly that is developing from those abnormal vessels. They are not proliferative, they're not tumors, yet they expand with time. And very commonly, these are somatic and are associated with other syndromes, and we'll talk about that. The International Society for the Study of Vascular Anomalies, or ISSVA, you can find this at issva.org. It is a free website, and there's this interactive chart, which is really the basis for the definitions that we're going to be using and the definitions that we ought to use when we communicate with each other. On the actual website, these blue entries, when you click on those, they lead you further down into the diagnostic algorithm. So again, you've got the vascular tumors, you've got the vascular malformations. Under the tumors, they're benign, locally aggressive, and malignant, and we'll talk about these. And under the malformations, we've got a whole host of things. So this classification is the one that we need to use and the one that we need to perpetuate so that we can communicate in dealing with these patients. So we'll talk with malformations first. And we classify malformations by the vessels that are involved. So remember, these are inborn errors of vasculogenesis, and they can be arterial, they can be venous, lymphatic, capillary, or as this Venn diagram shows, combinations of all sorts. You can have arteriovenous or capillary venolymphatic, and we see all of these combinations, and they all have a particular course and particular treatments. The most common malformation are the venous malformations. And most of these are associated with a mutation coding for the tunica intermedia of endothelium tyrosine kinase. So we know that the vast majority of venous malformations, there is actually a mutation that has been identified. There is a loss of the normal cobblestone layer of the muscle. So the smooth muscle cell attractants are abnormal. So there's a destabilized wall. So instead of having this multi-layer, very smooth and integral wall, we have actually this very floppy and very unstable, through which the blood flow is very slow, it's stagnant, and leads to spontaneous thrombosis and thrombolysis. So localized intravascular coagulation is a process that is ongoing inside of venous malformations. And that has led to the identification of the fact that D-dimers, which, as you know, the D dimer is a fragment of protein associated with the dissolution of clots. It's been identified as a biomarker. So elevated D dimer in a healthy person otherwise is a marker for a venous malformation. So that's important to know. Within the lumen of these malformations, there is this constant coagulation and inflammation leading to phlebolyths, which are a pathognomonic on imaging studies. The natural history of these is that although they are congenital and present at birth, they may not necessarily be apparent at birth. So there are times, and I'll show you examples of where the venous malformation or the malformation was clearly present at birth, because that is the definition. It is an aberrant congenital vascular problem. And they're characterized by slow growth throughout the lifetime of the individual. They never, ever get better. Now, they may grow at different rates, and they may have something that's very slowly progressing that is never an issue, or you may have something that progresses more rapidly and does present a problem to the patient. You can also have instances of growth during infection or trauma, during pregnancy, during puberty, in response to hormones. So this is a whole host of vascular anomalies. This is a young woman who I saw, happens to be the daughter of a physician whom I've known for years. I knew her as a child. And then all of a sudden in her 20s, when she was pregnant, this large mass appeared. And it turned out to be a venous malformation. So under hormonal influences during pregnancy, that lesion grew and became apparent, even though technically was present there her entire life. This is obviously a much more severe version with overgrowth of veno-lymphatic malformation with overgrowth of the limb. This is a veno-lymphatic malformation of the tongue with overgrowth of the mandible. These are small venous malformations associated with blue rubber blood nevus syndrome, an arteriovenous malformation, and so the classic cystic hygroma or lymphatic malformation. So some of the nomenclature that we used to use, such as cystic hygroma or lymphangioma, are terms that we don't want to use anymore, because we now want to talk about what type of malformation it is, and this is a lymphatic malformation. A capillary malformation, which is progressing over time with nodularity, and we'll talk a little bit more about those in detail. So the treatment goal for malformations is to either affect total removal, which is possible sometimes, but most importantly, and the most likely course of action that we have to take, is to control growth. So if you think about this as an aberrant, abnormally developed vessels, it doesn't seem very common that you would be able to cure that entity, because it's more diffuse, not as localized. However, occasionally we do have that opportunity. But in most instances, we're setting the stage for further treatment. We're controlling the growth with a variety of different options. So we have surgery, which occasionally we can use as a curative modality. However, most of the time when we operate on these patients, it is for control, reducing the bulk of the lesion. Laser treatment with a variety of different wavelengths, which do different things, can be used. Medical treatment in general has to do with supportive care, anti-inflammation, anticoagulation, compressive garments of the extremities and the head and neck. That's very difficult to do. And then more recently, we're using some of the metabolic pathway inhibitors, which we will talk about here in just a few minutes. But the mainstay of treatment, and this is why multidisciplinary, multi-specialty cooperation is important, is interventional radiology. So the mainstay of treatment for most VMs, LMs, AVMs is sclerotherapy or embolization. So we have a very close working relationship with IR colleagues, not only on the imaging side, but on the interventional side. Treatment of capillary malformations, or colloquially known as port wine stains, can be used, like I said, with laser. Virtually all the port wine stains will respond to laser treatments. However, very, very few, if any, actually clear completely. And again, if you think about that, this is a congenital malformation of the vessels in this area. So by closing them down and by making these vessels shut off, we are seeing less of it on the surface. However, if you wait long enough, many of these patients, the malformation will reappear because the vessels continue to expand under the hydrostatic pressure over their lifetime. Lymphatic malformations of mucosa, there are a variety of different ways to treat. You can resurface the mucosa by ablating the layers and then getting remucosalization over time. However, the deep portion of the malformation is still there, and over time will come back up. And this is now a case where we would use now one of the medications, which is rapamycin, which we'll talk about, like I said, I've mentioned a couple of times. But so again, there is no cure. The question is, how do you control this in a young child for whom this is going to be an ongoing issue over time? Small venous malformation on MRI is localized to this area. One of the few times where we can go in, cut it out, and it's cured. Not the most common scenario. More commonly, we have a venous malformation involving, the superficial area of the skin, the deeper structures, and in areas which are functionally and cosmetically an issue. So of course, we have the technical ability to remove all of this with great morbidity to the patient. So instead, what we do is we debulk the area, remove what seems prudent, and then treat the remainder of the lesion with either laser therapy or the deeper sections with sclerotherapy, again, preserving function, preserving aesthetics or maximizing aesthetics, but knowing that this is a temporizing treatment because we cannot cure the underlying venous malformation. Remember, these are the vessels that are affected have mutations in them, which we are not able to cure or change at this point in time. There's a woman who came to me having had several operations for a, quote, hemangioma. The surgeries had been aborted due to blood loss. And this is not a hemangioma. It is a venous malformation. She's an adult, a persistent lesion, and we'll spend a lot of time talking about this under the tumor section. But here you have a lesion which is growing over time and in an adult. So it can't by definition be a tumor. It is expanding and has been there since birth. And it is like I said, a venous malformation. We did, again, one of the fewer times where we were able to resect, because the deep surface, of course, is the skull, and this had not involved the skull. So we were able to resect the entire lesion and do a microvascular free flap. And then she's able to wear a wig. And again, control of this lesion surgically was possible, though again, this is not the most common way to deal with things. This is an AV malformation with ulceration, had been previously embolized. You can see some of the embolization material here. It's called onyx. It's one of the materials that they use. And the area ulcerated, so we were able to go in and resect that and replace it with a microvascular free flap. And at some point, if this boy is interested, of course, then you can do hair transplants and all sorts of things. But again, this is again a not very common instance where surgically we were able to salvage an IR procedure. This is a young girl from UAE who I've been treating for years now, and is the one from that original photo that I showed. She was originally treated as a hemangioma, and of course what she has is a venous malformation. So on MRI, there's a lesion extending into the cheek, and we've done a variety of treatments, including surgery, debulking. We have done intralesional laser therapy, and we have done sclerotherapy. So again, this is over time controlling this lesion. There is no cure that we have. On the MRI, she still has lesion that is underneath here, which is being controlled, like I said, with a variety of less invasive modalities. A young girl with a massive malformation of the tongue that we brought, and you can see here on imaging, and this is after multiple treatments with sclerotherapy, laser therapy, and eventually orthognathic surgery, where this young little girl is now able to, and she's now in elementary school or middle school here in South Carolina after being adopted by the family that brought her from China. As I mentioned, port wine stains are technically capillary malformations. They are of varying degrees, and they inexorably get worse over time. So here you see these nodules. I think I showed a gentleman with a very large venous malformation, capillary venous malformation of the lip. And occasionally, the reason that I'm mentioning this is that when we see a capillary malformation involving the forehead, or what traditionally would be called the V1 distribution, we need to worry about Sturge-Weber syndrome. So whenever we have an ipsilateral capillary malformation and a typically ipsilateral leptomeningeal malformation, that constitutes Sturge-Weber syndrome. You have to have involvement of V1 or the forehead for this to be Sturge-Weber. You can't have just V2 or V3. And the reason for that is that the development, remember, these are congenital problems in vasculogenesis, and the ectoderm contributes both to the skin and to the leptomeninges, and that is where the malformation is. That is where the mutation is. And then due to increased metabolic demand, as these children are growing, there's a very common association with seizures before the first year of age. There's association with glaucoma, and what has traditionally been called, quote, a choroidal, or the choroid of the retina, hemangioma. And we were actually able to show that the mutation in the brain, in the skin, is the same one in the retina. So these are actually not hemangiomas, but actually a capillary malformation of the retina. And so again, this GNAQ mutation has been now associated with Sturge-Weber syndrome. And like I said, the description has changed because hemangioma has a very definite diagnostic and treatment implication, which we'll talk about on the tumor side. Sirolimus is the medicine, which I have mentioned a few times, which is now being more commonly used in some of these malformations, particularly lymphatic venous malformations. It's been around now for 10 years. I'm sorry, for 10 years in the treatment of vascular anomalies. It's becoming more and more common. We'll talk about it a little bit more as to its involvement in the pathways in just a second, but it is, again, another example of a drug that is being repurposed. So rapamycin or sirolimus has been used for a long time as an immunosuppressant for transplant surgeries and transplant patients. And because of its position of inhibition in the metabolic pathways, which I'll show you, once we knew that the malformations had a similar problem, we were able to then translate the use of that drug to these patients. And now, not only as in this paper, there was the original paper was as a compassionate use. There were basically patients who had failed everything, and that's who the Dr. Adams and her team treated. Now we're using it early on in children who would otherwise perhaps just have to wait to see how big the malformation got, or in children that we really don't have very many other options, but we're using it in far less complicated malformations. At this point, I'd like to switch over to the tumors. Again, this is from the ISSVA site. There's the benign tumors, the locally aggressive ones, and the malignant ones. I have no experience with malignant tumors, so I won't be talking about those as far as the vascular ones, but we are going to talk about infantile hemangiomas, congenital hemangiomas, and some of these other entities as well, and again, the most common ones. Congenital hemangiomas are, again, these are now tumors. So remember the vascular anomalies, malformations, and now we're talking about tumors. These are true neoplasms. Congenital hemangiomas, as the term implies, are present at birth, and we'll talk about the two types. KHE is the other tumor that we'll talk about, and then we'll spend the remainder of the time talking about infantile hemangioma. So congenital hemangiomas are completely, fully formed tumors at birth. And then they take on two very distinct paths. There are those which are rapidly involuting or rich, or non-involuting congenital hemangiomas. So very interestingly, these tumors are present at birth. A subset of them within the first year will start regressing, which mimics the infantile hemangiomas, which we'll talk about, and some of these do not. We don't know why, and we'll talk about some of the reasons why may or may not happen. And another thing that you need to remember is that these are all GLUT1 negative, and we'll talk about the importance of that again, and just if I keep on putting things off, but it all will make sense hopefully at the end. So glucose transporter 1 is negative in congenital hemangioma. So here is an example of a rich, present at birth, not growing, not proliferating, fully formed, and then over the first year of life regresses and involutes. Same thing on the arm, over time it involutes, and then we went back and actually excised this extra skin. A non-involuting congenital hemangioma would look the same as this over the first year of life, and then those need to be treated most of the time surgically. KAPOSIFORM Hemangioendothelioma, or KHE, is a locally aggressive vascular tumor. They're characterized by these firm, bruise-like macules. They're on palpation. They're pretty well defined, and they're firm on palpation. They're typically unifocal, as these are, but they can involve the lung and other abdominal viscera. As with all the other tumors, except for one, which we'll talk about, it is also GLUT1 negative. And the reason this is an important one to know is one, that it doesn't respond very well to some of the treatments that, that this lesion gets confused with. And number two, it is the only vascular anomaly associated with Kasabach-Merritt phenomenon. Again, this is the only vascular anomaly associated with Kasabach-Merritt phenomenon, which is a rare consumptive coagulopathy. There's platelet trapping within the lesion, and there's elevated D-dimers, anemia, and such. If in the clinical situation of that with a congenital vascular anomaly, KHE is the diagnosis that we try to exclude or to determine. We'll spend the rest of the time talking about infantile hemangiomas, and hopefully some of these other things will start making more sense in comparison to these. So IH is the most common benign tumor of infancy, not just vascular tumor, but the most common benign tumor of infancy. It affects, depending on the studies, 5 to 10% of newborns. There's a female to male predilection, so little girls are more commonly affected than males. The vast majority occur in the head and neck area, which is how I got interested in them, and because one of my sons had one, and they're then distributed throughout the rest of the body. But the sites of predilection are on the face and in the head and neck, and we'll show you how that fits into some of the treatment regimens that we have. Most of these are not present at birth. They appear within the first couple of weeks of life, though some of them are present at birth, but then they change. So as opposed to a congenital hemangioma, which the tumor is there and doesn't do anything or regresses, infantile hemangiomas, there may be something there present, but then it rapidly starts growing. They're very commonly associated with low birth weight babies, and it increases 40% per 500 gram of decreased birth weight. So that's why we see twins, triplets that tend to be smaller babies with increased incidence of hemangiomas, not because they're multiple births, but because they're very low birth weight babies. The hallmark of IH is, again, that these are endothelial neoplasms. They are true tumors, but they're very special kinds of tumors because they exhibit a very peculiar natural history, and that is they rapidly proliferate, and then there is a gradual regression, and that is where all the confusion comes in with treatment. The gradual involution happens 100% of the time to some degree over some period of time. So one of the messages that hemangiomas don't just go away, they don't disappear, and I'll show you what actually happens with these. But this is the natural hallmark, is proliferation and regression. The vast majority, and I mean nearly 100% of lesions, can be identified on physical examination and by history. Very occasionally we'll use imaging studies, not for diagnosis as much, but for extent. And again, when there is a question, when we're trying to determine, because by history, this baby is very young, we don't have a lot of history to look back on, we can't tell whether it's a KHE, or in more rare situations where we can't tell whether it's a malformation or an IH, infantile hemangiomas are the only vascular anomaly that are GLUT1 positive on biopsy. So this is a differentiating marker on biopsy when we have to use it to tell the difference between vascular tumors and malformations, but more specifically between infantile hemangiomas and everything else. I'd like for you to look at this slide very carefully and take a look at what it says, and then I would like for you to forget about it completely. So these terms are old terminology which should not be used anymore. They don't add any description. They're historically important because of how they came about. But when we talk about hemangiomas, we want to all be using the same terminology. Not only is it a tumor, but we can talk about what kind of hemangioma it is based on the cutaneous involvement of the lesion. So we have superficial lesions, which are involving the upper layer of the dermis and grow outward. We have deep lesions, which have involvement of the deeper dermis and grow downward. And then we have compound lesions, which are, of course, both. We can then further say that this is a focal lesion as opposed to a segmental lesion. So when I call you on the phone and I tell you, or on Zoom, on audio only, and I say, I have a baby with a focal, superficial, proliferating hemangioma of the nasal tip, immediately you know what that is. However, if I called you and I say, I have a stork bite involving the forehead, it doesn't mean anything. It doesn't really describe anything based on the biology that we know of these of these tumors. As I mentioned, you can have focal ones and segmental ones. Segmental ones are important because they are more commonly associated with other developmental anomalies. Two particular areas that we concern ourselves with. So a segmental infantile hemangioma involving the lumbosacral area has a higher incidence of associated cord dysraphias, imperforate anus, urologic problems, so what is called lumbar syndrome. Same thing, a segmental hemangioma of the V3 or mandibular or beard distribution has a very high incidence of subglottic hemangioma. So we want to be very cognizant that in a situation like this, almost 2/3 of those children will actually have a subglottic hemangioma as well, which of course is important for treatment and prognosis. Segmental lesions tend not to do as well aesthetically as focal lesions, and that's why early diagnosis and treatment, as with most of these, is very important. A segmental lesion, which is very common and that needs to be paid attention to, is facies, which is the association, as the acronym shows, of posterior fossa malformations, hemangiomas, arterioanomalies, carotid arch, and such, cardiac defects, sternal and other midline deformities, and eye abnormalities. So again, this is another segmental hemangioma, which needs special attention, special imaging in this case, to identify some of the arterioanomalies because it has some implications for treatment. So where do these come from? This is a sequence of pictures taken by families. We see this all the time. All of us are used to taking pictures of our children, and these families in particular start documenting everything because they see this thing that's happening. So here's at birth, and these are labeled by the parents. And then within a few days, they started noticing that something started appearing and started getting more bright red. This is a set of twins. You can see one where there's this red superficial lesion, and then this other one has this halo around it. And we'll talk about the significance of that with IH. So we don't know exactly where these come from, but there is a group of hypotheses for which all of them, there's some evidence, but there's no causality yet established. We do know that there's some stem cell and progenitor cells that give rise to epithelial cells. It's part of vasculogenesis. There are some stem cells which are derived from the hemangioma itself. And then there are two particular pathways which we'll talk about, which are extremely important. So if we look at the EPCs, or the endothelial progenitor cells, these are the ones that under normal circumstances will differentiate into the vasculature, endothelial cells, okay? And it turns out that in infants with IH, there's a 15-fold increase in circulating levels of CD4, which is a cluster of differentiation, different types of cells, but these are the ones that differentiate into epithelial cells of the vasculature. There's a 15-fold increase in circulating cells. So there's something that has created more of these cells, which then potentially lead to these tumors. On the molecular level, I've mentioned a few times that GLUT1, glucose transporter protein 1, is the only one that is positive in these vascular tumors, is in hemangiomas. It's also interesting that GLUT1 is uniquely co-expressed with a few other tissues. The placenta, for example. If you then look at the transcriptome, which is that portion of the mRNA which is actually expressed, there's a huge similarity between placenta and IH endothelial cells. So if you take a lung cancer, for example, and compare the transcriptome of the lung cancer to the lung parenchyma, there's a lot of similarity because one is derived from the other. The thought is that there's a link between placenta and IH. They both express GLUT1. The transcriptome is very, very similar, but we don't know what that link is. If you take these multipotential stem cells that are GLUT1 positive and you implant them and grow them, they actually recapitulate in a very, very short period of time what happens with hemangiomas. These cells very rapidly start dividing, they proliferate into tumors, and then over time regress and become replaced with fibrofatty tissue. Exactly what happens with hemangiomas. The pathways that are involved, the most important one of these is the VEGF, or the vascular endothelial growth factor pathway. It is one of the most highly conserved pathways in humans. Genetic deletion of the receptor, VEGFR2, leads to uniform early embryonic lethality. So it's very highly conserved and very important. And the setup on the cell surface is that VEGFR2 is really the active, that most actively expressed receptor, but it is very low during normal states. It is upregulated during angiogenesis, neovascularization, whether it be malignant tumors, benign tumors, or even during healing. And then VEGFR1 is a dummy decoy receptor, so that most of the VEGF is harvested or is bound to the VEGFR1 receptor, except for in cases where increased angiogenesis is needed, in which case there's now increased activity on the VEGFR2. So, and then of course you have downregulated, or say our downstream effects that lead to migration of endothelial cells, proliferation, et cetera, et cetera. In hemangiomas, there has been a mutation found, not in all, but in some, of tumor endothelial marker 8 on the VEGFR2 receptor, which leads to increased VEGFR2 expression. Now there's more circulating VEGF that is bound to VEGFR2. There's less VEGFR1, and you have increased angiogenesis, migration, proliferation. So all these downstream effects are upregulated in hemangiomas. Not all of them. And again, there's no causality established yet. And finally, the placental hypothesis, as I mentioned, there's some correlation or some relationship there. And if you look at babies that have systemic hemangiomatosis, and there's an increased incidence of hemangiomas in patients who have had chorionic villus sampling, with placental abruptia, with placental trauma. And the idea, hypothesis, is that these embolic showering of the baby from these EPCs or hemangioma stem cells, progenitor cells, get lodged in the baby and then start doing their thing. Again, correlation, not necessarily causation. And the final thing before I put all of these together is that in some cancers, we know that there's a predisposition to where that cancer goes, right? So we know the brain tends to go, that prostate cancer, for example, goes to bone, and breast cancer goes to lung. I mean, there's some areas of predilection. So there is a theory that says, or a hypothesis, that the actual niche where these cells are attracted to are somehow prepared by the tumor cells themselves, that there's something that ends up in that area, which then attracts those particular cells to theirs. This is the metastatic niche theory. So what is it at that niche that might be the attracting factor? And the things that are under investigation are hypoxic-induced factor alpha, VEGFR2, and beta-adrenergic receptors. So if we look at where hemangiomas, the sites of predilection, where do the hemangiomas most commonly appear? They tend to be along embryonic fusion planes in the head and neck when we look at the face, okay? So what happens at those areas? One is that they're end arterioles, they're end vessels, right? And then there, if you look at where some of these occur, you see not uncommonly this halo, this vasoconstriction halo. So the area around what eventually became a hemangioma is vasoconstricted, hypoxic. So HIF alpha leads to increase VEGF and erythropoietin during normal healing. We have trauma to a vessel. We have release of these factors downstream. We have these things. We have sprouting. I mean, all the normal healing things as a result of or in response to hypoxia. In the area of hypoxia, it's been documented that there is an increase in beta-adrenergic receptors, okay? Beta-adrenergic receptors are upstream of the expression of HIF-1 alpha, which we just talked about, is in response to hypoxia or trauma or some abnormality in that area, which leads to increased VEGF. If we now have all of these things put together, this is not actually proven, but if we sort of think about that there are progenitor cells that come from the placenta or the tumor itself that have a mutation in VEGFR2 or others that then have that there's a niche that is prepared for whatever reason, and there's increased HIF and there's increased VEGF, and these cells end up there, that then there's something that switches on to cause these tumors to proliferate. And the question, or one of the thoughts right now, is that that switch is that beta-adrenergic receptor, which leads to one of the treatments that we'll talk about here in just a second. So to recap, if we look at the natural history of hemangiomas, they are typically not present at birth, very rapidly within the first few weeks of life appear, and then they rapidly proliferate. The curve of proliferation is most acute in the first 2 months. Sometime around 6 months, the tumor plateaus and then starts regressing. Very unusual tumor. Proliferation, regression happens 100% of the time. However, it happens to some degree over some period of time. So this ended up like this and doesn't necessarily go away, okay? So here are again patient pictures, family pictures. Lesion appears, lesion proliferates, and this child is being told to wait, leave it alone, it will regress and go away. Yes, it will regress to some degree, but it is very unlikely that this volume of tumor is going to regress to an acceptable place. What happens during proliferation? If you look at these under the microscope, you see that these are solid tumors. There's endothelial cell hyperplasia, very few vascular channels. During involution, these endothelial cells start regressing, and the stroma of this is being replaced by fibrofatty tissue. So this isn't disappearance, it's replacement, and which is what we expect to happen in the human body. Things don't just disappear. Now, if something starts off being 2 millimeters and gets 75% smaller, it may be acceptable, not visible, of no consequence. Something starts off as, 15 square centimeters and the tissue starts regressing, you can get all sorts of residual changes. The skin gets stretched out, you've got telangiectasias, you could have cartilage deformation, doesn't happen very often. But the point is that the bigger these start off, the less likely it is that they will involute or regress to an acceptable level. So this is the dogma that I was taught when I was in medical school and is still being taught in medical schools today, is that 50% of these will go away in 5 years, 70% will, quote, go away in 7 years, et cetera, et cetera, et cetera. And again, this is not what happens. This child, what is going to happen now between the 5th and 9 years that you can expect this stroma to go away? It's just not going to happen. And we know it doesn't happen. So if you look at all comers, hemangiomas from 1 millimeter to as big as they come, the majority involute to an acceptable functional and aesthetic level. And that's because the majority of these are very, very small. However, about 30% of them will need treatment. And if you think about that 5 to 10% of live births are affected by these, we're talking about a huge number of children, okay? And if you follow the 30% that don't involute to an acceptable level, if by 6 years of age, it has not reached an acceptable level, the vast majority of these patients will show up at some point saying, what can you do for my child? Or what can you do for me? Because this isn't going anywhere. Now think about the patient that has a malformation that has been misdiagnosed. So now you have a 6-year-old or a 15-year-old or a 20-year-old that has a malformation that is getting bigger. They're being told to wait because it's a, quote, hemangioma, and it will go away. Or it will get. So you've got these two groups of patients that are being ill-served by misdiagnosis. Those that are malformations and being told that they're hemangiomas and that they go away, and those that truly are hemangiomas and are being told to wait when there's really no real chance that they will reach an acceptable level. So what is acceptable? So if you look at this child right here, you see these two very small superficial focal involuting hemangiomas, and over time they have reached what I think is an acceptable level. If you look very closely in person, there is a little bit of a scar, but most people would say that's acceptable. Same thing. So now we have a compound in early involuting hemangioma of the lower lip, and this is what happened after involution. So did it regress? Absolutely. Is it acceptable? If it was my daughter, I would probably be saying, oh, I wonder what else could be done to make this better. And that's exactly the same as this other child that I show you, which I met at this stage. And again, the parents were being told it will go away with time. And there is just no reasonable expectation that that's going to happen. If we then look at the natural history of the tumor itself and map out the development of self-image, which is very interesting, okay, by 18 months of age, if you place a Post-it note or rouge on a baby and you put them in front of a mirror, they will instinctively remove that Post-it note or wipe at that rouge, okay? That's around the time that hemangiomas have started involuting, and the slope of the involution curve is at its greatest. Prior to that time, that child has no concept that that is them in the mirror. By 3 years of age is when self-image or self-consciousness is most already ingrained. So a child is walking around and somebody says, "What's that?" And they're pointing to this thing on their nose. That 3-year-old knows that it's about them. And this is a set of twins where every time you ask them to take a picture, this child would start crying because she knew that it was because she was different than her sister, okay? She knew that there was something different about her, and that is what ends up happening. And that's just normal development. And certainly by the time children are starting school, 5, 6, 7 years of age, at that point, clearly that child knows that this is not the same as his parents or his siblings or whatever. All the other 5 or 6 year olds are noticing the same thing. And is there any expectation that this is going to resolve to a point where it is acceptable? And I would say no. So this is where we talk about now, what are the potential treatment options that we have? We can affect total resolution of the lesions with treatment. We can treat complications, or we can set the stage for further treatments. And the timing of this is very important, and it is all very dependent on when this child walks into the office, right? So at different times along that curve, different times during the development of self-consciousness, different times during the natural history of the tumor will determine what seems appropriate to treat, which option is appropriate to use. We may choose to watch. It may be so early on, and it may be in an insignificant location somewhere on the body, that we may choose to see what happens. We may choose to use lasers, medical therapy, surgery. We're going to go through each one of these. So observation is not telling the parents, leave it alone, it'll go away, we'll see you in 5 years and it'll be fine. It is an active decision to follow the lesion and monitor its progress, and then allows you to intervene at any point. Laser treatment, multiple modalities or multiple wavelengths, and we can talk about this for hours, but basically oxyhemoglobin is the main target. The most common laser that we use is the pulse dye laser, and we can affect total removal of very, very thin, proliferating superficial lesions, because the laser is able to penetrate throughout the entirety of the lesion. Again, and there's lots of things to talk about regarding laser treatment. About 10% of hemangiomas will ulcerate. The pulse dye laser is very helpful in healing the ulcerations. Now, in this body part, on the buttocks, healing the ulceration is very important, and most of the ones that do ulcerate are in the diaper area, unfortunately, or some of the central parts of the face. So now that the ulcer is healed, we can decide whether there's something else to do or not. In this area, perhaps not. Same thing, an ulcerated compound focal hemangioma in this area, now it's healed. However, this isn't the end of the road for this. This is not an acceptable result at this location. So again, we can set the stage for further treatment. Medical therapy can be used primarily as adjunctive treatment or as definitive treatment. So again, as definitive treatment or as adjunctive treatment to buy time with impending functional loss or actual loss. The medicines that we're going to talk about are these, and then interferon and vincristine are really not used very much at all in the United States for these children because of the high incidence of neurologic problems. Corticosteroids, briefly, are extremely effective. It was the mainstay of treatment. They suppress VEGF-A, which now you know is very important for the proliferation of hemangiomas. And this is just a study which showed that in the presence of corticosteroids, the microvessel density was much more reduced. A number of hemangioma stem cells were less. So again, the proliferation was suppressed. This is a young child with a deep, compound, periorbital, cervical lesion, which I treated with steroids. She has proptosis, which resolved with the steroids. We used the laser to treat some of the superficial areas, and she is now in her 20s actually, and got a good result from that. Sirolimus or rapamycin, which is the drug which I mentioned that is being used more commonly for malformations, may have a function with hemangiomas. So as I mentioned, VEGF-A is bound to the VEGFR1 and 2 receptors. You have the the protein kinases, which downstream lead to cell growth and migration. Well, mTOR, or the mammalian target of rapamycin, is part of that pathway which sirolimus inhibits. So the blocking of mTOR, which then downstream leads to a decrease in HIF-1 dependent expression of VEGF, can lead to decreased proliferation of hemangiomas. It does work with venous malformations. In hemangiomas, we actually did a study where we implanted hemangioma tumor tissue in nude mice and then used topical rapamycin. And you can see how the rapamycin inhibited the growth of that hemangioma. There is theoretical laboratory evidence that this works. However, what happened, and we do use it in malformations and like I said, in other things, but what happened in 2008 changed the course of treatment and also is one of the reasons why rapamycin is not as commonly used as it might have otherwise. And that is that in 2008, there was a case report of a couple of children from France and Belgium that had large segmental hemangiomas that were being treated with high-dose corticosteroids. They developed cardiomyopathy because of the steroids. They were placed on a beta blocker, propranolol, to treat the cardiomyopathy, and the corticosteroids were stopped. And guess what? The hemangiomas started regressing. That started the use of propranolol for infantile hemangiomas all over the world. It is a non-selective beta-adrenergic antagonist, and it is now the most commonly used medical therapy for infantile hemangiomas that are proliferating. They cross the blood-brain barrier, and I'll show you why that's important in just a second. There have been several studies in the meantime that have shown that the presence of different beta-adrenergic subtypes in hemangioma, which may lead to different types of beta blockers being used, which may have different side effects and that type of thing. So there have been a variety of different receptors expressed in IH now that we know that that seems to be an important thing, remember, related to HIF and the vasoconstriction and all that kind of stuff. So this is what a beta agonist does, okay? So a beta agonist increases vasodilation, promotes angiogenesis, and inhibits apoptosis. Propranolol is a beta antagonist. It decreases or inhibits vasodilation, actually causes vasoconstriction by decreasing the pathway from nitrous oxide. It blocks angiogenesis by blocking some of the pathways that we talked about leading to this cascade leading to proliferation. And it actually promotes apoptosis or cell death. So these three mechanisms are thought, has not been proven, but this is what we think, are the ways that propranolol affects infantile hemangioma treatment. These are children that convinced me to use propranolol. I was a very late adopter, but this was a child that the parents said was treated with propranolol, and during the time of the natural history that we would have expected this tumor to grow, it actually shrank. This is a child that I took this picture here that was treated with propranolol by somebody else in this part of the natural history, and it shrank much faster than I would have expected based on my experience. And now propranolol has been shown to promote regression, inhibit proliferation, and like I said, it is the standard first line of medical therapy for the treatment of hemangiomas. However, I want you to focus on the quote after pictures. This is not the end of the road. This is not where things end for this patient. So this is where I very commonly see patients for the first time, okay? So they've been treated. The pediatrician may be happy that in fact, and there's a good reason to be happy. However, in this location, is this as good as it gets? Is there something else we can do? And that's why we mentioned about setting the stage for further treatment. In this area, it may not make any difference. Hemangiol is the propranolol formulation that I use. It is one formulation. There's only one solution, as opposed to generic propranolol, which comes in various different concentrations and can lead to prescription errors. But again, that is, you know, a topic for discussion at some point. The main effects of beta blockers, of course, we know the side effects are potentially bradycardia, low blood pressure, stymieing the effects of the symptoms of hypoglycemia, and sleep disturbance because it crosses the blood-brain barrier, as I mentioned. And it turns out that in the studies using propranolol, this side effect, which is the most serious one, happens in less than 1% of healthy babies. And this, which is the most common side effect, sleep disturbance, happens in about 10%. So 90% of babies continue to sleep as poorly or as well as they used to, and less than 1% have any of the side effects that we worry about. So it's extremely safe, has a very large margin of safety. Contraindications, typical things for beta blockers, a child who has asthma or a child who is unable to eat or drink or is having some other issues that would potentially mask the side effects of hypoglycemia. We now, 90% of the time, write a prescription and start hemangiol as an outpatient, whereas initially we used to do it as an inpatient with a lot of pre-dosing workup, which again, we can talk about more specifically. There is a topical formulation, which is an ophthalmologic formulation, which can be used for very thin lesions. Excuse me. Sorry, I was going to sneeze. However, the limiting factor, of course, is the penetration of the medication through the stratum corneum. There's no really great preparation for this, but on very superficial lesions, I will occasionally use that. I don't use it on the hands because the children put it in their mouth, and that's really the only way that this preparation can be very, very dangerous because of the concentration. This is a combination of using propranolol plus the pulse dye laser. Again, using the propranolol to decrease the rate of proliferation, and then over time, increasing the rate of regression, and then using the laser to treat the superficial telangiectasias. As a surgeon, I have to show surgical pictures. It is a requirement. And we can affect total removal of the tumor. We can set the stage for further treatment with laser, other surgical treatments, and we can treat also sequelae and complications. Surgery has been fraught with misconceptions that these tumors are bags of blood and the baby's going to bleed to death and such. As I showed you, histologically, these are solid tumors. They are not fed by numerous vessels. There is really no significant risk of bleeding within, what we all as surgeons, take as common practice. They do not infiltrate surrounding tissues. They push tissues away. This is from a video just to show you that here is the compound hemangioma. You can see the superficial component. You can see the deep component. There's the normal junction of the two. When we incise that area, the tumor kind of pops up because it's a solid tumor. There is always a plane between the tumor and the normal tissues. When we cut into the hemangioma, it is solid. It is not a bag of blood. And then we can close the area with whatever mechanism seems appropriate. Here is a compound lesion of the lower eyelid. where removing the entirety of the lesion would lead to proptosis. So we debulk or remove most of it. We then leave this to either involute or treat with laser. She and I are now friends on Facebook, so I'm able to follow pictures, many years later of her progress. Again, just to show the plane between the deep portion of the hemangioma and the normal tissues. This is early on, but again, just to show that this is a solid tumor. This is that same child that I mentioned before, which again, technically we could remove the entire thing. However, the goal for surgery is primary closure. We don't like to do flaps and grafts on these children. So what I've done is operated or debulk the tumor from within. So you can operate, you can create a plane inside of the hemangioma and then remove a vast portion of it, still close things primarily, come back and remove another portion at some other time and treat with lasers. And this is again, many years later on Facebook, where there is no way that this lesion would have involuted to an acceptable degree, no matter how long she was told to wait. Similar thing, again, not to belabor the point, but surgical excision, laser treatments, and then several years later. Nasal tip is an area that I'm extremely interested in. And again, just to show that the tumor can be removed, separated from the lower lateral cartilages and from the structures of the nose, and the skin laid down in an anatomic position. Again, the tumor splays the lower lateral cartilages. It doesn't invade the lower lateral cartilages. This is a young child that was on the cover of Archives of Facial Plastic Surgery when we published this. And again, we often use non-anatomic incisions. This is the same child, and this is her on that cover, and this is her many years later. She sent me a selfie, which again is not great quality, but at least it shows that from an aesthetic point of view, she is confident enough to carry on with her life. Similar type of thing, what used to be called the Cyrano nose, Cyrano de Bergerac type of nose, after surgery, laser treatment, and here she is. Literally 20-something years later. I just saw her in my office. She lives here where I live. Again, removal of the tumor in one operation can get us to a point where waiting years couldn't do that. That same child that I showed, that was the lower lip. Much later stage, this lesion is fully involuted. It is not doing much else biologically, and in one procedure now sets the stage for eventual scar revision as needed. When we have lesions that are too big to remove in toto, one of the things that we published and that we started doing some years ago is the same concept that we do for congenital nevi. Sometimes the nevi are too large, so what we do is we take a portion of it and do a serial excision. So we took a portion of the hemangioma, taking advantage of the fact that it is a solid tumor, and closing that part primarily, waiting a few months, coming back and doing that again. And you keep on doing that as many times as it takes, and eventually get to a point where the result is acceptable and the lower eyelid has been saved, whereas there's no way that we could have technically removed that without compromising her lower eyelid function. Similar type of thing, an ulcerated hemangioma, scarring, serial excision, and that tissue advanced medially along with laser treatment. Very large lesion. First child I used propranolol on, serial excisions, laser treatment, all of the changes of the nose You can see very early on, there wasn't much there. Then the lesion continued to proliferate, which started propranolol. And then all of these changes and eventual result had to do with the drug, had nothing to do with surgery. Same patient, this area serially excised and then set the stage for further scar revisions and touch-ups as needed. One of the things that I've started doing in the last couple of years is for these deep residual involuted hemangiomas. If this child would have walked in some years ago, to excise this would have required a very large incision. Again, just taking advantage. This is just a picture of a different child to show, as I've already mentioned, that they're solid tumors. Well, now what we do is we make very small, minimal access incisions, use an ultrasound aspirator, which saves little vessels and little nerves, and we're able to debulk through minimal incisions and then flatten out that area and then use a laser to then touch up the residual vessels. So whereas before it would have been a very large incision, now we have 3 very small incisions and a more reasonable outcome. Again, 1 very small incision here. This is the flank. In the glabella, same thing, and then set the stage for further treatment with lasers. So these are all just options. So is there a consensus for management? And the answer is yes. So if we look at, and we published this a few years ago, if we looked at, and we looked at only nasal tips, but if you looked at all the literature and you compare it to my personal experience, I was doing it this way. If you look in the literature, most of us were doing very similar things. The big difference was in the timing of the procedures. So we know, based on everything, personal experience, community experience, the literature, that there is a consensus that multimodality therapy is important in the management of these lesions. Early on, during the early part of the natural history, medical therapy is very important. It's important to try to reduce the rate of proliferation. Laser therapy may be used for very superficial lesions. As the tumor has become more established, again, we don't have control over whether a child walks in the office here or that the very first slide that I showed you with a very, very, very superficial lesion. So once the tumor is there, then medical therapy can continue. Once involution starts, surgical therapy comes into play. And it turns out to be that a multimodality method is what works the best. The key is to intervene at the appropriate time. And if you think about the timeline of development of self-consciousness, then that gives us some, as a facial plastic surgeon, we do otoplasties, right? So for large ears or protruding ears. Well, the dogma has always been to do it around 6 years of age. Why is that? Well, because by 6 years of age, the child's ear is approximately 90% of an adult size, right? So it has grown enough, we're not stunting growth, but also that's around the time the children start school. So the idea was to maximize the timing, both anatomically, functionally, and with social developmental issues. I say the same thing is true for hemangiomas. The timeline's a little bit different because we have the ability to intervene very early on and then still prevent these children from walking around with these tumors that have no chance of getting better to a reasonable degree without intervention over lots of years. So in summary, I just want to make sure that I've made the point clear that hemangiomas and malformations are 2 distinct entities. They're part of the vascular anomalies family, but diagnosis is extremely important because misdiagnosis can lead to mistreatment. The nomenclature that we should all be using is that of ISSVA. So again, we can communicate very effectively. And again, that the multiple treatment options are available. Vascular anomalies which appear or grow within the first few months of life should be evaluated. So pediatricians and family practice doctors are the first ones to see this. Make sure that the diagnosis is appropriate. If a lesion is proliferating in a cosmetically or functionally sensitive area, it should be evaluated. If a vascular lesion is persistent after 2 years of age or so, it should be evaluated. Is the diagnosis correct? Is this really a hemangioma, in which case we know that not much more is going to happen? Or is it another type of lesion that has other implications for much longer in this patient's life? And again, and treatment should be geared toward maximal functional cosmetic benefit commensurate with the developmental, developmental milestones of self-image, which I have already mentioned. And again, I guess the dogma should now be, leave it alone, it will go away, is not universally acceptable advice for vascular anomalies in this day and time. And I want to thank everybody for the opportunity to do this. My email is here, should I can be of help to anybody. And at this point, I would like to turn this back over to Professor Ashish and take any questions if there are any or any comments. Again, thank you very, very much for this opportunity.
Thank you very, very much, Professor Marcelo Hushman. This is a great lecture. We enjoy it too much, and it is very, very informative and fruitful, and exploring and covering all the aspects of vascular anomalies, from the diagnosis up to the management and surgery and even treatment. And so if you don't mind, I will just start with two simple questions. Then I will give the opportunity to my colleague to ask if they like. The first is, do you still believe, or you can still accept selective angiography or selective embolization to the feeding vessels to the large hemangioma in the lip prior to surgery, before surgery, or now at that time no need for this? What do your comment?
So for hemangiomas, infantile hemangiomas, in my experience, I would say that interventional treatments such as embolization are just not needed. And the reason for that is because, again, it depends on when you go in to do surgery. Some of these very large parotid hemangiomas, or lower lip, that type of thing, early on are very biologically active, right? So very large tumors can be very vascular. However, that may not be the time to intervene surgically, and that's a time to intervene medically. And then later on, down on the other side of the natural history, where the tumor has become much more quiescent and biologically inactive, now we can remove things, and bleeding is just not an issue. Malformations, totally different ballgame, totally different ballgame. Their IR is very important, and sometimes we use it, many times we use it exclusively, but sometimes we use it preoperatively. So we will have the IR colleagues do embolization, and then within 48 hours, we'll go in and remove a portion of that venous malformation. But for hemangiomas, that type of procedure just doesn't really seem necessary for the vast majority. I'm sure there's some case, but in general, I would not say that would be necessary.
The second question is, you end up in your lecture about one of your recommendations. You talk about the sensitive areas, or sensitive functional areas. So this is raised the part that in lymphangiomas or hemangiolymphangiomas, when it affects the cheek. So this is a really big challenge for us, because we are keeping in mind the facial branches, facial nerve branches, and in most of the cases, it is near to the skin, and uh, and also the high possibility of recurrence, particularly the lymphangiomas. So, what's your suggestion for that? How to keep all the branches of the facial nerve intact, and also to avoid, and by all ways it will recur. So, are you believe that we should take not that much extent because it is going to come back again, or what's your
Sure.
plan for that?
Yeah, so that is one of the lesions that is extremely difficult to treat. So, and I didn't spend any time on this, so we can talk about that. But lymphatic malformations are typically divided into macrocystic and microcystic. Macrocystic lesions, those that have larger areas of cystic component, can either be very easily and well treated by percutaneous sclerotherapy, very good results. Microcystic, which is more infiltrative and is very difficult to treat with sclerotherapy. There are some places that do that, but the vast majority, but this is where sirolimus or rapamycin now has a role for the control of lymphatic malformations. In those that we decide to operate on, and again, in the oromandibular area, they're a real problem, and it's not my area of expertise, but where you have mandibular involvement and infra and suprahyoid compartment involved, it is a very difficult problem. In those areas where we might choose to go in and operate, sirolimus has now become a very important part, especially in the extremities. It reduces the bulk. It is actually better to treat with the medication before the scarring of surgery and all that, because more of the medicine gets into the malformation. I have more experience operating on venous malformations involving the parotid space and the buccal space and the facial nerve and all that. And in those, one of the things that we do is a technique of mapping out the facial nerve with our neurophysiology colleagues in the operating room, as opposed to the traditional way where we stimulate the nerve. This is actually monitoring the nerve so that as you get closer, it is detecting the nerve potentials before you actually might even see motion. So again, it gets very complicated and very technical, but there is no easy answer. And the reality is that it's not recurrence, it's persistence, right? It's that we haven't removed everything, and that's okay, because removing everything may have such a bad morbidity that it's not worth doing. So it is, it's a whole different thinking than the tumors, for sure. So it's a very difficult problem. I don't have any perfect answers for you.
So thank you, Prof. I will give a chance to my dear colleagues, Dr. Mohammed Saud, the maxillofacial surgeon from Riyadh, and Dr. Muhammad Ali, the vascular surgeon from Asir. If they have any question, please.
Yeah. Yes, Dr. Marcelo, thank you so much for this interesting lecture. I have one question regarding the tongue hemangioma, what to do? And I want to ask you if you prefer to wait until the size of this hemangioma regression by itself, or you start the treatment as early as possible. And also I want to ask about the recent treatment of injection of interferon alpha-2 in this type of hemangioma. Thank you.
So the tongue as an anatomic area most commonly is involved with malformations, not hemangiomas. Now, hemangiomas can be found there, not as common. So if it truly is a hemangioma, as we've described the terminology, then I would say earlier treatment is better. In fact, for all vascular anomalies, earlier is better, because the earlier you recognize what it is and the earlier you intervene, the better the long-term result. Now, that doesn't mean that we are aggressively intervening at every step, and there may be times where it's just not appropriate and we wait and see what happens. But in general, observation is part of the treatment. It's part of knowing what to look for next. So assuming that this is a tongue.
Yeah. So when I can take the decision for cut off, when the surgeon start to cut off.
So again, it depends on the natural history of the lesion. So for tongue malformations, again, earlier is better. I mean, as soon as the diagnosis is made, you could have a very small, very focal lesion of the anterior third of the tongue that may be very easy to remove without any functional consequence, or you could have a moderately large lesion of the base of the tongue, which would be technically possible to remove, but the functional impact is bad. So that's where interventional radiology really ends up being the mainstay of treatment and control.
Yes.
So Dr. Muhammad Ali
Thank you so
from
much.
Artierio. Dr. Muhammad.
Thank you, Dr. Marcelo, for this great lecture. I'd like to ask about the cornerstone to differentiate between venous malformation and hemangioma.
So again, if you think about these as totally distinct entities at the biologic molecular level, hemangiomas are proliferative tumors of endothelial cells. Malformations are embryologic aberrations of development of vessels. So that leads to two completely different entities. And clinically, again, it's a matter of putting all those things together: the presentation of the child, the age of the child, the history. That establishing the diagnosis is critical, because it does lead to different treatments. I'm not sure if that answers your question. There's one question that says, do patients get heart failure from large or huge hemangiomas? And you can, I mean, those are not as common. I mean, again, the days of the gigantic hemangiomas is getting less common, because the focus is becoming more and more on early intervention. However, that's why it takes a multidisciplinary approach, including cardiology and our pediatricians and all that. So but I guess the answer is yes, it can happen. And if it's recognized, then, one of the areas that is an issue is liver hemangiomas. So large liver hemangiomas can present with very severe hypothyroidism. Again, I mean, that is out of my area of expertise. So you have to have the pediatricians and the other specialties involved. And so in general, that's the case for all of these lesions, is that you really need to have a multidisciplinary approach, because we all have areas that we're very good at. Very few of us can do everything, so it's important to have a team.
Any other question from audience, please? Okay, thank you again. Thank you very much, Professor Ashman. It was a great that we are with you today, and hopefully, one day when COVID-19 disappears and leave us in peace, so you will be most welcome to visit our group. It will be a great pleasure. And thank you very much.
Well,
for
thank
all
you.
what
It
you
would
do.
be my privilege. And again, if I can be of help either by email or otherwise to anybody who's on the call, please let me know. But again, thank you for the opportunity to share this with you.
Thank you very much. Thank you. Have a nice time.
You too. Thank you.
Thank you.